Dr. Stites is not yet here, but we do have Dr. Hawkinson, and we also have Ashley. She is a nurse on the front line. We thought it might be interesting for you to be able to ask Ashley some questions. And so I think what we'll do is let them each introduce themselves and get an update, and then we will open it for questions.
Hey.
Ashley?
Ashleigh Adams, BSN RN.
This is Dana Hawkinson, infectious disease physician and medical director of infection prevention and control.
All right, each one of you, could you just give us a little bit of a statement about what maybe has changed in the last 24 hours, or maybe what's the same and what you're doing, how you're spending your time?
Yeah, I would say that, again, I think the infections are still increasing. We are continuing to see more positive patients around the city and around the region, in the hospital as well. And so we would still like to encourage and certainly endorse the public health guidance and continuing to stay home and social distancing, because we really do need to try and stop the spread as much as possible.
And then with nursing at the bedside, it has changed quite a bit with the increase of the positive COVID patients. It's kind of different than what we were taught in nursing school and what we've been doing here at KU, but every day we're getting set up for success and giving all the information we can possibly get to educate ourselves, our families, and friends. Just keep doing what they're saying. It's working.
And Dr. Stites, your timing is perfect. You're up next. If you want to grab a seat, we're using microphones that are not attached as we continue to practice more social distancing.
Right.
So why don't you go ahead with having everybody introduce themselves and then talk about what's changed in the last 24 hours or 12 hours.
All right. Well, good morning. My name is Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Things are changing rapidly, and we're beginning to see an increase and an uptick in the number of positive patients here in Kansas City. And so we have more positives here in the hospital, we just learned today, and we know that we have even more patients we're having to rule out, which we expect part of those to be positive. So I think, we're starting to feel the surge and working really hard to make sure we have enough supplies and equipment, knowing that if that surge continues as we expect, then it's going to be, it'll be a challenge. And so whatever people can do to stay home and stay safe is how we can make sure we have enough. And, we've started giving that message about a week ago, and we won't know if that message has really resonated and worked well with our listeners and the people who live in our metropolitan area in greater Kansas and western Missouri. We won't know that for another week. I hope and pray and believe that it will work, both because we have less density, and I think that Midwesterners tend to be a socially conscious lot on something like this, and that they will work hard to make sure that they're following the advice of our elected officials and health officials, because it will make all the difference in how we do. We just can't emphasize that enough.
All right, reporters, please say your name and the affiliate that you're with, or news agency, so that we can go ahead and take some questions now. We have about 30 minutes.
I'll go first. This is Jessica McMaster with 41 News. Dr. Sykes, you said something that speaks to what I was going to ask. You mentioned that you are awaiting tests for other patients who you believe will be positive, and I was speaking with a physician assistant who was a friend of mine back in Detroit who was telling me while there aren't enough tests for COVID-19 or the tests take too long, you can get an indicator of if people have contracted the virus based off of other lab draws that you're doing. Can you explain that, and if that's helping in one aspect where you're waiting on the COVID-19 testing?
Yeah, I'm going to actually, Dana Hawkinson, our infectious disease doc, and start with that. There are some things we look for. It's not definitive, but I'm going to let Dana address that.
And I agree with Dr. Stites. There are lab values that we can look at, but again, nothing is definitive. because we see those abnormalities in lab values in other conditions as well. Certainly in the published reports, the most common types of lab abnormalities would be a decrease in one of the types of your white blood cell count, your lymphocytes. That's maybe about 65%. Sometimes you can have an overall decrease in your white blood cell count. That's about 50%. And then some other people will get elevation of their liver enzymes. Overall, though, those laboratory are not confirmatory, and those changes can be seen in a lot of other disease entities as well. So they certainly would help, but at this point in time, we are not using that for diagnosis, no.
Another question?
Casey Jones from KCTV5 News here. I would like to know, so a lot of people are sitting at home, they are wanting to find ways to help out. Some of them are sewing masks, homemade masks, and hoping to donate them to medical professionals. Is this something that you would accept, and would this help you?
You know, we so appreciate the efforts of people that are trying to rally around us and help. The struggle for us with homemade masks is unless they're made at a biologic grade, which is pretty specific about the kind of material that's in the mask, then the masks actually don't help us. They may not be impermeable to the secretions or to the virus spread. They can get wet easily, and that can set up a nidus for where the virus can live. And so it's not the same as having on a mask that we would have. And so, again, I'll turn to Dr. Hawkinson, but the thought is generous and heartfelt and wonderful. The struggle is, how can we use those masks for health professionals? It may be better for a patient to wear, so if they're coughing, they cough into the mask if they don't have something else. Dana?
Yeah, I would agree with that. And a lot of times, too, even when our biologic grade and our hospital grade and the ones that are tested for use in hospitals and healthcare facilities, even at that point, when those masks do get wet, either by coughing or just the water vapor that you breathe out, they are at that point rendered useless, because then they do tend to act like a sponge and just attract different particles and different things in the air. We absolutely appreciate everybody trying to help and do their part, possibly for an ill patient out in the community. But at this point, we still, as Dr. Stites said, kind of aren't able to accept those things. The other concerning thing is that when people have masks on, I think they feel secure and maybe then do not do the standard things that we are trying to reinforce, such as continuing to wash your hands and not putting your hands around your face like that, especially if you have to manipulate the mask. So that could really add to possible even further exposure. And so those are one of the reasons why that can be dangerous and provide a false sense of security.
And just to say, you might find some people saying, oh, we want all those masks, that's great, can you have them? Yeah, if you really examine the data around this, it's not the perfect thing. If people want to know what they can do to help, perhaps the best thing is, and it's so frustrating and it's so boring, it is to stay home. You want to help us? Stay home. Because that's what's going to keep you out of the hospital. And that's good for you, and honestly, that's good for us.
Ashley, why don't you talk a little bit about your care at the bedside? What are you seeing? How sick are the patients? What are they receiving in terms of care?
Right now at the bedside, it's been very different. Our unit has switched over to taking COVID positive patients, so that was a shift just in 24 hours. Right now, our patients are pretty restless. They're exhausted. That's what I'm seeing a lot of coughing, just general malaise. They're just very tired. And right now, they're scared, and they are. And, you know, previously, we were taking rule out COVID patients, and the relief that they would see when we would come tell them, hey, we got your test back, it's negative. And you could just see in their face, like, whew, you know. And so right now, with dealing with the positives, you're not seeing that. They're not getting that relief. And so right now, it's just trying to ensure them, comfort them, give them what they need. They're already away from home, so it's hard. it's hard. And then now we can't have visitors, and for understandable reasons, it makes completely good sense. So we're encouraging phone calls, and we've seen an increase of phone calls from family, and we encourage it. We'll answer, we'll do the best we can, and just try to be there for them and their families in this time.
And can I just say some of the unsung heroes here? You know, Dan and I get to come up, we're talking to y'all every day, but our nursing staff who has stepped up, none of these folks thought a few months ago that their unit that they've been taking a certain kind of patients on, because their patients are geographically assigned based on the type of illness, they get expertise in that. Nobody knew they were going to have expertise in COVID, and so some of our frontline teams who are exposing themselves to COVID-19 on a regular basis are the folks who have just said, our units have just converted. And so hats off to them. My patients are, well, no, and it's very true. Darn right. And for example, I do cystic fibrosis and lung disease. So Unit 15 was one of the first units. They converted, and they were like, yep, okay, let's go.
Right.
And I know that's what you guys did. And to see people pull together like that is a remarkable story. And again, I just come back to the same message. Our teams are doing those things, and our nursing teams are going out front line. If people will help them by staying home and staying safe, then we don't put our teams at risk. And so it's just, boy, you ask what you can do, that's what you can do.
Jessica again with 41 News. The past few days I've been reading a lot about, and if I butcher the name of this, I apologize, I'm not a doctor, cytokine storm. That's in the body of patients who've become critically ill. I want to explain what that is and what that means.
Okay. Dan and I looked at each other and said, which one of us is going to try and explain cytokine storm? So your body has a lot of mechanisms to try to kill foreign things, and whether it's a bacteria or a virus. You know, they don't just go away. Your body responds to that, and the way it responds is to say, hey, that's not supposed to be here. Let's go attack it. And you can attack it with missiles and machine guns and all sorts of stuff. Well, imagine that your body's launching that kind of a war against these foreign bodies inside of you, this virus inside of you. And so sometimes that works pretty well, and sometimes it's like the body just lost control of that war, and it starts launching so many missiles and so much artillery that the artillery starts to break down your own structure. And you think, well, why does that happen? Well, it's because it's lost control of that. Well, one of the things that happens in really severe infections is that you have this storm, this release of all this artillery that your body has, but it loses its ability to coordinate it, and so it starts attacking everything. So the focus of the infection may be the lung, and you think, okay, well, let's go attack the lung, but that cytokine storm, that artillery attack, starts to destroy the lung. And by the way, it spills over everywhere, and then it starts going after the liver, the kidneys, and a key one is the heart. And we know that when the lung and the heart are both struggling in COVID-19 and the heart starts beating irregularly, that we're in real deep trouble. And so that's kind of what cytokine storm is. Imagine it's an artillery assault that lost all of its coordination, and suddenly you're firing everything at once, and it spreads throughout your body. That's what a cytokine storm is.
And in addition to that, and I'll try and be brief because I know there's other people on the call, are there certain things that people might be taking at home thinking it's helping their immune system that could actually be making them more at an increased risk? Whether, we've read a lot about Tylenol versus ibuprofen, and even I've been reading a lot about elderberry increasing cytokines or cytokines.
Cytokines, Dana.
Yeah, as far as home supplements, this is a chronic issue with people taking home supplements and taking other actual FDA-approved medications. This is a general problem because we don't know exactly, number one, what's in those formulations, what is put in during the manufacturing process, the overall interactions of those substances with the medically approved and physician prescribed drugs. So I don't know that there's a lot of data to suggest that those things actually do improve your immune system or improve your ability to fight off COVID or any other infection. Certainly they are reported that way and marketed that way. But for many of those things, There's probably not a lot of good peer-reviewed medical literature to suggest that they actually do help. And so I would caution, if you're starting to take those medicines or those supplements, please make sure that you're not taking any other physician-prescribed drugs that would interact and have severe or deleterious effects on your health in general.
I just come back to that.
Tylenol versus ibuprofen. Is there an issue there? Because we're reading that a lot too, that you're not supposed to take, I think it was Advil, if you think that you have COVID-19. Is there anything to speak to that?
Yeah, again, this goes back to even prior to COVID. We understand that certain medicines, NSAIDs, which ibuprofen is one type of those, it's a non-steroidal anti-inflammatory, they can cause issues, certainly, for instance, kidney injury, especially if you have another illness going on that could affect the kidneys. I don't know that there's specific data, and there hasn't been specific published data saying taking ibuprofen a couple times with COVID is specifically harmful to you. But again, in general, for this general type of medication, we know that if you're severely ill or moderately ill, you can certainly have bad effects on other organs such as your kidneys.
So just to say a couple of quick thoughts. One, if you really want to do what's right for your body, sleep right, eat right, don't drink too much alcohol because that's going to depress your immune system very clearly, and stay really well hydrated. The basics, right? It always comes back to the basics. So in this world of COVID-19, there's fear and there's knowledge. We don't have as much knowledge about this particular SARS coronavirus as we do about, let's say, influenza. And so in the lack of knowledge sometimes, especially at a time of fear, people start making stuff up and they prey on you. And you have to be really careful that the things that are being said, oh, this drug revs up your immune system. Oh, this drug really gives you a powerful boost to your T lymphocytes. Really? Really? Who showed that? Where did that come from? Or is that just something that's on their website and they just write? And so at a time of fear and panic, people have to be careful they don't fall victim to that, which could actually make their health worse. And so I think to Dana's point, stay to the things that you know are going to really work. Sleep works, eating well works, don't drink too much alcohol, staying really well hydrated. Those things work. And that's what I think. And staying home, that's what works.
Hey, Andrew at KCTV here got a question about false negatives. They're starting to appear, and they appear to be kind of high at 30%. Are you guys seeing issues with that, with people that test for the symptoms, it comes back negative, but then they actually have COVID-19?
Yeah, so the data on that's a little sketchy. We're pretty early into some of that, but the number one problem is not the test itself, and that is how we run the test here. The number one problem is how the sample's collected. You have to do the right job in collecting the sample, and if you just kind of go into somebody's nose with a swab and know it hurts, okay, well, I'm not going to put it in, we'll put it in a bottle and send it. Well, that's not a very good sample. Somebody described to me, and I've had one of these actually, is that it feels like a brain biopsy, and it sort of does. If you've got the right sample, it's not comfortable. If it didn't, and this sounds terrible, but if it doesn't hurt and make you feel like it's kind of getting really way back there, then the truth is the sample probably wasn't very good. That's the problem with this. It's not really the processing of the test. It's did we do a good enough job? So in the right hands of the person who knows how to do this test, the sensitivity and the specificity is very strong. And it's if people don't know. And you're shaking your head. Are you doing some of these, Ashley?
Oh, I most definitely have done them.
And yes, and don't you think people feel uncomfortable?
It is. They send us the tube and what it looks like, and the stick to collect it is about this long. And
just so if you can't see it, that's like that's a ruler.
Yeah,
that's like a
I'm
foot
sorry.
long.
Yes,
Yeah,
it's
like
pretty long compared to our swabs we do for flu and other things, and so it's got this red mark on it of how far you're supposed to insert this into someone's nostril. And so you see this and you're like, okay, this is a little intimidating at first, but I'm like, okay, we're going to one and done this. I've had to do it on a few patients now. And I'm like, if we're going to do it, we're going to do it right. So be ready. It's going to be uncomfortable and I apologize. But you go in and you just think if you're not in there far enough and you can still see that red line, you're still not in. You have to keep going. So we were making sure, like, we are getting the sample right so we don't have to do this again.
Yes.
And that's kind of how I explained it to my patients, like, let's do it once. Let's
Just
get it
once.
done.
And you got to go in, then you're just kind of moving around a little bit.
And you have to, and not only do you put it in, and then you have to wiggle it around a little bit to make
Yeah.
sure you're getting that sample on there. So I've done a few.
Yeah, they're not comfortable.
It's not
Yeah.
fun.
This is a bit of an issue that you're running into. Are you guys taking precautions with this? And it sounds like there is a benefit to doing another test again if you suspect something's not quite right with the sample.
Yeah, I mean, I think overall we have, again, very good nurses at the bedside who are trained in getting an adequate sample. But certainly if we run into that, we also have our clinicians who are on high suspicion for this disease. So typically, a lot of these patients would continue in the same isolation precautions, and we have protocols to work through to get another sample to test again.
If we need to. And a lot of, but our I don't think our false negative rate's 30% here. And when we have repeated them, we don't see many positives. The other thing to say is that if you get somebody really early in the disease, they may not be shedding as many viruses. So if you wait 2 or 3 days later and you retest, and all of a sudden they're shedding more, and you have a little better chance of having positive. But I think a 30% false negative rate is higher than what we're seeing, especially in the hands of people who know how to do the test.
I have a question. This is Mackenzie from Channel 41. Could you talk just about the age group that we're seeing some of these positive tests? It seems, looking at some of the numbers, that the 20 to 29-year-olds are contracting COVID-19, but it's also kind of the age group that feels they're like immune to it. So I was just wondering if you could kind of speak to that.
Well, I'll start with this one because this is like a softball to me. Yes. I don't care how old you are. Stay home. Because you're right. People who are younger, first of all, it's just harder. You get a little more energy. You want to go out. I'm 60. I can go out, and I'm happy to go home and stay at home at night. But I think that, yeah, anybody can get the disease. The question isn't, can you get the disease? Every age group can get the disease. The question is, what will it do to you, and what will you do to the next person you give it to, right? If the average person, there's this number from CDC that says if one person infects 2.2 people, that's kind of the cutoff. And that's what we think the disease does. If every one person infects 2.2 people, that allows the disease to perpetuate. And we think that this particular one runs between 2.2 and 2.8. If we can get it down to 1, the disease will go away. That's the key thing. How do you get it down that one person may make one other person sick, but that's it? How do you do that? You stay home. You don't go out, and you don't be in contact with a bunch of people. People want some magic answer. That's the doggone answer. And so, yes, it's true about every single age group. The next question is always, well, who gets sick? Well, everybody knows. It's those of us who are 60 and over, and especially 70 and over, and having having comorbid diseases. That's what's probably going to land you in the ICU. But you know what? There are exceptions to that, and we do see some young people who get sick and die from this. So don't think you're immune just because you're young. You can still get really sick, and you can still spend 2 or 3 weeks in the hospital, and you can still die. But more than that, for the 20 to 30-year-olds, don't be a vector. Just because you think you won't get sick doesn't mean that you won't make somebody else very sick.
Mm-hmm. I have one other question. So people that are testing positive, when do they know that the virus has left their system? Are you guys testing them again and they have to, have a negative test, or how does that work so they know that they're okay then to eventually, when all this kind of goes away, we can go back to work and they can be around other people, things like that?
Yeah, currently in the hospital, we aren't retesting at this point in time. If they're able to be well and go home, we're able to discharge them if they medically aren't needing an increased level of care. There is certainly guidance from Kansas State Health Department, and I haven't looked in the last couple days, but before they were requiring at least 2 negative tests 24 hours apart. Those things may change, and correct me if that has changed, but certainly we would ultimately like to retest. However, we should understand that this virus can be detected for 2 to 3 to 4 weeks after symptoms, but again, does that mean you're actually able to infect people? How much virus are you shedding? Because as Dr. Stites had said, these tests are very sensitive and very specific and can pick up very small quantities of the virus. But to answer your question, that is certainly the guidance, is to repeat testing at least 24 hours apart, twice, to make sure you're negative. But currently we aren't doing that here. Because, again, the patients that are well, we do send home to be self-quarantined and then contact their local health department for further instructions and guidance on that.
Increasingly, if you've been out for 14 days and you're afebrile for 72 hours, you're probably okay. I'm going to look now at Ashley. I want to ask my own question to you. As people get ready to discharge who have had this, are they feeling better?
Not necessarily.
They're still kind of feeling
They're
crummy.
still feeling icky.
Yep.
Yeah, that's
So it
the
takes
best
a
word to
while to
say
feel
it.
better. You know how if you had the
Yeah.
flu, you're often sick for 6 weeks? All right, think about this like that. But that doesn't mean you're communicable for 6 weeks. It just means you don't feel great.
Nick Starling with 41 was asking, he said he couldn't be on the call, and he texted me. He wanted to know, a lot of people are offering to print 3D face shields and, the PPE. Is that in the
That's
same
actually pretty
category?
good. No, that's different because those guys are doing biologic grade and hospital grade. So we actually are working with a couple of different groups here in Kansas City and sourcing things locally where we can. And I think we're going to be taking some face shield orders today to help protect our staff, because I do think it's actually really valuable. Helps preserve the length of life of some of our masks, especially our N95 masks. And there's a national shortage. You can't go get them from our normal suppliers because the supply chain is so interrupted right now.
Andrew again at KCTV. Talking more about just kind of the social distancing aspect that we were kind of touching on earlier. Realistically, how long do you think social distancing and staying at home procedures will need to last in this scenario?
I can back that up.
We look at who's going to be the bad guy on this one.
We probably have the same opinion on that.
We probably do. You go for, I'll go. Okay. So, Dr. Norman was here the other day for our media conference. He said February 2021. I said, gosh, that one hurts. That's a long time. Here's what we know. We know that we have a less dense population. That's going to be better. New York City, 28,000 people per square mile. I don't know what Kansas City is off the top of my head, but it's not that. The next highest is San Francisco, 17,000 people per square mile. San Francisco and California took early action to try and get people to stay at home. Go look at the curves. They're very different between San Francisco and New York. So my hope is that by doing the things that we have done, by social distancing, by staying at home, sheltering at home, and by wash your hands, not touch your face, that I'm going to cross my fingers and hope by sometime in the summer I will be at Royals Stadium watching the Royals take the field. And I'm going to tell you, the first time I go there, I am going to stand and cheer, and I'll probably cry, because that'll be a sign that we're better. And I can't wait. I can't wait to watch the K open up and watch the team run out on the field. I will be very emotional at that moment. Dana?
I would absolutely like to second that. Certainly we've seen Hong Kong. They had an improvement and then took their foot off the gas, and now they're seeing more cases. If we do happen to see an improvement in this next week or two, we have to remember that all it takes is one big church service or one mass or one concert at Sprint Center or one concert at the Midland, and you can have one person who's infected, and then all of a sudden you have many people who are infected. And this spread can start again, and that curve can get more steep, and it won't be flattened, but it'll be even higher. And so we have to continue to do the right thing and stay home and really continue to try and flatten this curve, because we are certainly not out of the woods yet.
And I think part of the problem is we don't know enough yet. And we know the countries that have been most successful at mitigating this, Singapore, South Korea, Japan. And Japan's crowded, it has a lot of density, but they were able to do this really through social distancing, staying at home, contact tracing, and the things that try and prevent the spread of the disease. But it will be constant vigilance for quite a while, and we won't be back to normal, fully normal, and that's going to take longer. And when I say it's going to take longer, it's hard to know the exact time frames. We don't know enough about this coronavirus. We don't know what its seasonality is like, and that's going to figure in a lot. What I pray is that it's going to be like SARS, and it's just going to end. But I don't know that that's going to happen. It could still be in the population. It could be like one of the other, and the SARS-CoV-1, which is the what happened up in Toronto and other places. And that one just kind of ended. They did great distancing, they did great isolation and contact tracing, but it also just sort of ended. And what we have, it would be great if this one's like that. I'm a little nervous. It's a little more prevalent. It's a little more endemic already. I don't know that it's going to be like that. But what we want to see is through great social distancing, stay at home, all the things we can do, we'll get it to a low enough level that we can open back up the public a little bit, let folks get back to work. Big crowds are still going to be a no-no for a while, but I am hopeful to be at the case sometime this season.
I think we have time for maybe 5 more minutes, and then we need to let the doctors go. And Ashley, our nurse.
Okay, I'll take one more question from my producer here at 41 News. He's asking about spouses, that there have been cases where you're transferring that to a significant other. What are your recommendations in those cases? If you live in a home with someone and they test positive, should you bounce and go to a hotel? What do you do?
Oh, okay, got it. I didn't hear what you first said, but you're talking about in-home spread between one person who has it and one person that does not have it. Is that right? Yep, okay.
Yeah, I mean, I think that the rates overall on in-home spread vary depending on what publications you look at, from 10 to 20% to higher. It's really difficult to say. I think that the CDC website offers good guidance on that, on if you're unable to get to a hotel, about isolation in the household and cleaning things and staying away from other members of the household, if that answers your question.
I think the things to do are self-isolate. And then if you can, wipe down. And somebody says, well, I don't have any more wipe-down cloths. I can't get them at the grocery store. True. You can also take some Windex nasal spray. Not Windex nasal spray. Good grief. Windex and a good clean rag. Everything helps. It's not as great as having the 100% alcohol stuff, but you can also put 100% alcohol in a bottle and spray that. That's a pretty darn good antiviral agent, Dana.
Yeah, I think if you can do that, make either homemade solutions of alcohol. You can make a bleach solution. There's guidance for that on CDC and other places as well. There's also other household cleaners that can probably work to clean down the flat surfaces, continue to wash your hands, and do those types of isolation in the household.
Yeah,
All that
I
helps.
think a lot of it's non-intimate contact. The numbers drop dramatically.
Yep.
The truth about COVID-19 or COVID-2 is that it doesn't crawl across the floor. It doesn't magically jump from a countertop to your mouth. If you do the right things, it's actually, it's not that easy to spread. And so you just got to do the right things. And if you do that, that's the story.
How about final
Andrew,
comments? Or do you have one more question?
Yeah, Andrew Vin here, KCTV. One of the things that I've read a lot that seems to be changing very frequently, even just in a single day-to-day basis. Have we learned anything new, or at least what's the latest right now when it comes to how viable and how long the virus lives on surfaces like money, mail, packages, that sort of stuff?
Okay, Dana.
Yeah, okay.
How long is my money good for, Dana? I don't have any.
Give us some to me.
Yeah.
I'll take it all. This is a continual question as long as there's another one that we get a lot. We certainly don't know the answer to this. We suspect and are pretty sure that if you're getting mail, if you're getting packages, those are probably going to be safe. Those are mostly shipped in cardboard. They're fabric. So it's probably not lasting too long for those instances. Money, Dr. Fauci said it's probably not big or insignificant quantities. Of course, you never want to put your hands in your mouth after handling money anyway. But as far as on other surfaces, we just don't know. The half-life can be 5 to 7 hours, up to even detecting some evidence of the virus up to 3 days. But is that even detecting the evidence really significant in causing disease? It's really hard to tell. But we would think and suspect more than on things like fabric. It's probably even much less so than on other flat surfaces like steel or plastic. And if you're getting takeout or delivery from in paper bags or delivered, you're probably at pretty low risk. But still, a lot of people are just leaving the bags outside for a little bit, taking their food inside, leaving the bags outside. Those things can be done as a measure of further precaution. But as far as actual time, we don't know. We probably think it's less significant than other hard surfaces such as countertops, door handles, things of that nature.
Cell phones.
Cell phones. And then again, getting it, it's not jumping, as Dr. Stites said, it's getting it from the surfaces to your hands, to your mouth and your mucous membrane, such as your eyes, your nose, again, in your mouth.
All right, reporters, once again, I want to thank you for dialing in and your continued interest. You guys are really helping enhance our ability to talk to the community, so we appreciate that. Tomorrow, I am trying to get an emergency room physician to join Dr. Stites and Dr. Hawkinson so he can talk about what he's seen in the emergency room.
Yeah, front line, right there under for any patient coming in. I thought that would be a good thing. And I just want to say, I really want to thank Ashleigh for coming in,
Thank
because
you.
these guys, you don't know how much risk our teams
Thank
are
you.
taking up there, and so that they are the unsung hero.